Thank you, Cynthia, and it's always nice to be in New York. These are my financial disclosures, and the ones that are relevant are Bausch & Lomb and Alcon. So, we all, all this new technology, Panoptix toric, the new Symphony that's coming out with the frosted edges. It's all exciting technology, but if a patient heals funny, or if we iatrogenically induce something to the patient and the patient heals funny, we have an issue with some of these lenses. So I wanted to just share with you the purpose of this study that I did and presented at the ASCRS this year in San Francisco. And this was to stimulate and compare retinal imaging between aspheric toric IOLs with neutral and negative spherical aberration optics under conditions of tilt and decentration, as well as residual astigmatism. So the cornea was used, it's the Doubleman model cornea with a spherical aberration of plus 0.28 with a 6 millimeter entrance pupil. Chromatic effects were considered by using polychromatic light. Clinical relevant levels of 2.6 degrees of tilt, 0.4 millimeters of decentration, and residual astigmatism of a quarter diopter. Through focus, MTF optimized for best image quality, and it may not be the highest MTF peak, but we use negative spherical aberration, the Acrosoft IQ toric, which is a minus 0.2, Technis monofocal toric, which is a minus 0.28, and the neutral Invista monofocal toric, which is 0 spherical aberration. If you look at the photopic thing here, we're looking at the tilt and the decentration. If you look at the top one, that's the Invista. Acrosoft is in the middle, and Technis for all of the rest of the slides. And you can see the quality of the letter on the retina image is much clearer with a neutral. This is the mesopic with 2.6 degrees of tilt and 4.5 millimeter pupil with decentration of 0.5. Again, we look at this in mesopic conditions, and the quality of the retinal image is better with a aspheric lens. This is also photopic, but this is with 0.25 residual astigmatism, and the quality of the image starts to degrade with this, but it's still, with a neutral, still a little bit better. And this is in mesopic conditions, the same thing. So if you look at the defocus tolerance, the dark one is the theoretical defocus curve, and the top one is 42 patients of mine, and it doesn't. We notice that there's a lot less theoretical defocus of 1 line per quarter diopter of not reaching target. So this has a lot of tolerance for defocus, allowing the patient to have a good range of vision across the range. The retinal image simulation, in conclusion, the aberration profile of toric IOLs play a significant role in providing predictable visual outcomes. In the presence of residual astigmatism of 0.25 or greater, 2.6 degrees of tilt, and 0.4 millimeters of decentration, negatively aberrated toric IOLs showed more impact on the quality of image. So the aberration neutral showed better conditions or better residual aberration, fewer aberrations with this. So how does this attest to what we do clinically? Well, this is a patient, 72-year-old white male who underwent a uneventful cataract. He had blunt trauma kicked by his grandchild in both eyes, and he was also cross-linked after that because he had 4-cut RK. If you look at this is a eye trace showing, and the arrows are pointing to the zonulopathy, and this lens is certainly decentered. And if you look at the defocus curve here, it's showing a yellow refraction, which is not terrible, but it's looking to show about a diopter and a quarter of astigmatism at a residual axis of 60. But the bottom line is, this is the patient's post-op exam several months later. No ocular complaints, 20/20 vision at distance, 20/25 intermediate, J3 at near. With a quarter diopter sphere, he's 20/20. So let's look at another case, and this is the second case, and this is a 75-year-old white male who is undergoing MX60T, so the Invista toric, and I caused this iatrogenic tear by polishing the capsule. Fortunately, there was a capsular tension ring was placed, and I aligned the lens with the aura. This is the patient 8 months out, and look at the decentration on this. But remember, this lens is the same power from center to edge, so no matter where you look, the refraction is stable. And this is his eye trace showing a diopter at 25 residual, and the patient has no complaints. He loves it. He doesn't need to wear glasses when he rides his bike. He's 20/25, 20/20 intermediate, J5 at near. With plano plus 75, he's 20/20 plus 1, and he doesn't wear his glasses. And this is the last patient I'll share with you, and this is courtesy of Paul Singh. This is a 60-year-old white female who underwent uneventful cataract surgery in 2018, and a year later, these were her visions: 20/20 distance, 20/30 intermediate, J3 at near. And this is a decentered lens just found on an ancillary finding. So a dysfunctional lens analysis is done. The patient sees clearly. The E is beautifully clear. So how patients heal is very important. And this, if you look at the range of focus, we're getting about depth of focus of almost 2.5 diopters at near and a diopter at distance. So the effective range is of almost 2 diopters of defocus. So this is pretty cool. And the first 100 or so patients I did, this is uncorrected vision. 98% were 20/30 or better. 75% were 20/20 or better. But this is where this lens shines. And if you look at the intermediate vision, 86.5% of these patients were 20/40 or better, so they can read their phone. And almost 60% were 20/30 or 20/25. So this lens has performed very well for me. So why is this important? It induces no spherical aberration. It's equal from center to edge. It has broad haptics, 88 degrees, and it increased depth of field. So this is great in any patient, and it allows us to, natural healing sometimes can cause problems, but if you go in with an aspheric lens, you're apt to get a better outcome with patients that are much happier. Thank you.